Merci à vous également. Merci pour votre présence aujourd'hui. Donc, Inch'Allah, هنبداو. So it will be a light case today and a light presentation. So first of all, you can just type the www.menti.com and then enter the code so that you can vote. Because we will have some quizzes, but it will be some somehow most of them are easy quizzes, inshallah, just to learn new things in a fun way. And while voting, there is so your name will not be visible to others, so you can vote as you want because it's anonymous. Now let's begin. So I will just tell you a little bit about me for those who doesn't know. So I'm a 7th-year medical student. So I'm in my last year this year, and I'm deeply passionate about medicine and dedicated to helping others. I have some certificates and accomplishments that you can see. So, and if you have any other questions, of course, you can ask me about. And so, are you ready to embark on a journey to explore a new case together? You can type your answers here and it will show. So hope that everyone is ready. You can just say yes or I don't know, whatever. That's good. Sure. So I hope it's easy for you to use this this app. So let's begin. So our objectives for today is to understand and identify the etiology of today's elbow problem. So it's an elbow problem, but I will not tell what is pathology. To recognize clinical presentation and diagnostic strategies, also to enhance our diagnostic skills. So we will show the ultrasound and the key signs in it, and also to explore the treatment options and the management strategies. So we'll begin with our case. So it's 53 years old. And he has a post-traumatic swelling of the left elbow, as you can see. So we did a plain radiography and it revealed no evidence of traumatic features, such as fractures, dislocations, or bone abnormalities in the area of concern. So I hope that you know now the case. So we will repeat. It's 53 years old man. He has a post-traumatic swelling of the left elbow, and the plain radiography showed nothing. So now our question. So given the patient's history and clinical presentation, so if you want me to tell you more about his clinical presentation, so he has a history of minor trauma to the area 1 week ago. Also, the swelling is non-tender and there are no signs of systematic infection. So now, given the patient's history and clinical presentation, which is the most appropriate next step in imaging to evaluate the condition? So will you do an ultrasound, an MRI, a CT scan, or no imaging is necessary in this case? Okay. So as I told you, you can vote. There is no names here. It's anonymous, so just vote whatever you want. Okay. I'll let you some time for the people who want to join and vote. Okay, so we have two answers for now. We have the ultrasound and the CT scan. So the right answer was the ultrasound. And now we will see why. So it was the ultrasound because the ultrasound is preferred for soft tissue swelling, fluid collection, and bursitis, and there is no radiation exposure. For the MRI, yeah, it's good, but it's more of a follow-up. So if we want to see more details in the soft tissue, we'll do the MRI. And for the CT scan, it's best for bone injury, so it's not really ideal for soft tissues. Now we have the ultrasound. So now I will just let you see it for now. And after this, we will have a question about the diagnosis. So just try to guess what is the diagnosis. Okay, so now we will go into the question. So after performing an ultrasound, which diagnosis is most consistent with findings of localized fluid collection and bursa inflammation? Is it a lateral epicondylitis, which is called also tennis elbow? Or do you suspect an elbow osteoarthritis or an elbow hygroma or fracture of the olecranon? So now you can choose your answer based on the the clinical findings and the ultrasound that we did to the patient. Mm-hmm. Is there anyone who want to join? Mm-hmm. Okay. So should I give just 5 seconds, 5 more seconds, and then we show the answer? So 5, 4, 3, 2, 1, and here is the answer. So it's an elbow hygroma. We will see why. So the confirmed diagnosis was the elbow hygroma or olecranian bursitis. And it's due to, so there is, as you can see here, there is a novel shaped there's an oval shaped where circumscribed lesion of the olecranian bursa of the left elbow with here hyper echogenic periphery. And there's also here, as you can see, the fluid echostructure and the multilocular appearance. And it's featuring distinct hyper-echogenic frinks within lesion. Here is the frinks that you can see. So all of these indicates that it's an elbow hygroma. So I will repeat what we see here. So as we've said, there's an oval shaped here, an oval shaped, well circumscribed lesion of olecranian bursa of the left elbow with hyper echogenic periphery, and there is fluid echostructure and multilocular appearance. And it features distinct hyper-echogenic frinks within the lesion here. So those are called frinks. Now we'll go into to know more about this diagnosis. So elbow hygroma or olecranian bursitis. So first, here is a pic to understand. So this is a healthy joint. So as you can see, everything is normal. The bursa is within limits. Everything is good. And here it is the bursitis or olecranon bursitis, as you can see. So we have an inflammation of the olecranon bursa. And as a result, we will see a swelling, a redness, and a pain at the tip of the elbow. So now our next question. So what is typically preserved in a patient with olecranon bursitis? Is it the skin integrity around the elbow? Is it the range of motion in the elbow? Is it the absence of pain in the elbow? Is it the complete absence of swelling? So what will you not find symptomatic in your patient? What will be preserved? I know the question is a little bit tricky, but just try to understand it and then you will know what to choose. Would you find no pain in your patients having this condition? So, does anybody else want to vote? Okay. Okay, so the right question is the range of motion in the elbow. So the range of motion in the elbow is preserved. So when you will take your patient's hand and just move it, it will be moved and there will be no problem. But for skin integrity, no, there will be no skin integrity. We talked about the inflammation. So there will be inflammation, there will be redness and swelling, and there will be pain also. So all of these will be present in our patients. So it's not preserved. So now we will have a briefing about the clinical presentation. So for this condition, it's an inflammation. So we will have the patient will have an inflammation, a swelling, and pain in the olecranon bursa. Also, it may follow. So this condition may follow minor trauma or cure spontaneously. And if associated with infection, there may also be overlying inflammatory skin changes like erythema or systematic symptoms like fever. So make sure to search for all of these, especially fever, because it can change the way you approach it. And also, the elbow movements are usually not limited. So that's what we talked about. So all the motions will be preserved. Now to the next question. So a golf ball sized swelling over the olecranon after blunt trauma with preserved elbow movements most likely indicates olecranon fracture, cellulitis, olecranon bursa hematoma, or septic arthritis or septic arthritis. The word correct is mistakenly placed there. Okay, so try to think of what is the right answer. It's okay, all of us can choose whatever we want. We're not supposed to get the right answer We are learning. Okay. So does anybody else want to vote? It's okay. You can choose whatever you want. Like I've said, it's anonymous, so just feel at ease. We're just learning here. I'm still a medical student too, so okay. So now let's see. Okay, yeah, it was the right answer. So the right one to suspect is the olecranon bursa hematoma. For the fracture, it's there will be no movement preserved. So when you will try to move the elbow, it's fractured. So no, it will all the movement will not be preserved. For the septic arteriosis, it's a no, because we don't have here something that indicates an infection, and it's the same for cellulitis. So here is the recap, radiograph for the radiographic features. We talked about before, but we'll repeat. So the first thing to do is the plain radiograph, because it shows soft tissue swelling and potential olecranon spur. It may indicate underlying etiology like fracture or calcification. Also and then we have the ultrasound. It identifies fluid collection, synovial proliferation, or hyperemia, possible detection of loose body or triceps tendinopathy. And for the CT scan, it reveals fluid density in subcutaneous tissue near the elbow. But as we said, like the first thing to do is the plain radiograph and then the ultrasound. And it's the best for the soft tissue. And also there's the MRI that demonstrates bursal fluid collection with hypointense T1 and hyperintense T2 signals and enhanced bursal margins. So now we have the next question. Which of the following is recommended initial diagnostic step for suspected infective olecranon bursitis? So now you suspect an infection. What will you do? Will you do an X-ray of the elbow, an aspiration of bursal fluid for analysis, an MRI of the elbow, or a complete blood count? You have just one answer, so okay. Is there anybody who want to vote too? As I've said, it's anonymous, so feel at ease. Okay. I think I'll count to 5 and then go. 5 seconds. 5, 4, 3, 2, and 1. Yeah, it's the aspiration of bursal fluid for analysis. You guessed that right. Complete blood counts. Yeah, I understand from which perspective you choose this one. But in this case, specifically in this case, if it's an infection, we're afraid it will be something bad for the patient. So we choose the aspiration to know why, to know the etiology. So here is how it is done. Just a picture to make it easier for you to imagine. So in the case of gut-related olecranon bursitis, microscopy of aspirated fluid from the bursa would most likely reveal bacteria, urate crystals, or pus. So in the case of the gut-related, Does anybody else want to vote? So 5, 4, 3, 2, and 1. Yes. Good. That was a good one. And after this, we have our next question. So, what is the first line treatment for non infective olecranian bursitis? So, now you have your patient and you know it's a non infective bursitis. What will you choose for the treatment? Will you choose a corticosteroid injection, analgesia and NSAIDs, or antibiotics, or a surgical excision? Just think of it logically and then choose. And it's okay if you don't get it right. We are just learning here, so. Okay. So for the aspiration of the bursa, of course, we do it under aseptic condition, and we do, and it's an immediate microscopy for crystals or bacteria to confirm the good or bacterial infection. So after doing the bursa, we can know if it's a good or a bacterial infection, and and a small needle is used to aspirate the bursa completely. Okay, now you've completed this question. Okay, it was the analgesia and anesthesia. So now we will see the treatment and management, and I'm really proud of you for making it through till now, till the treatment. So the treatments and the management of this condition. First is the conservative treatment. So we have, it's like if you know the rice, but without the E. So there's R for rest, E for intermittent icing, and C for compression. And then there is the analgesics like paracetamol and anesthesias. So this is the conservative treatment and the treatment that is most used in this condition. And we have the aspiration of the bursal fluid, like we talked about, and it's it's not required because there is risks that include infection and sinus tract creation. So it's reserved for suspected unusual etiologies. And then we have the surgical bursectomy, and it's considered as last resort in cases of refractory to the conservative treatment. Like you've done the conservative treatment and there is no results. So after this, you can suggest the surgical bursectomy. And for the prognosis, so it's typically self-limiting within weeks with no chronic sequelae when managed conservatively. So it's a good evolution. You just do the conservative treatment and it will all go well. So this is our last question, I guess. So why should NSTs be avoided as a first line treatment for olecranian bursitis when an infection is suspected? So just think about it. Think more about the infection. Why we should avoid NSTs? Remember that it has anti-inflammatory effects. So should it be avoided because because antibiotics are ineffective in the presence of NSTs, or NSTs directly worsen the infection by promoting bacterial growth, or the NSTs increase the risk of hemorrhagia in infected tissues? So try to guess what is the correct answer. And if you choose something else and you want to defend it, you can defend it by writing in the messages or just talking. So it's your last question, so just vote. I'll count into five. So it's 5, 4, 3, 2, and 1. So it was because it directly worsened the infection by promoting bacterial growth. Because when we give the NSAIDs, it has anti-inflammatory properties, so it will make the infection spread. So you can just worsen your your patient's case. So you should make sure that there is no suspicion of an infection, so that you can give them. So our take-home message for today: exercise caution with anesthesias in potential sepsis cases, because they may elevate infection risk and complicate outcomes. Like your patient may just be coming for a simple infection, and then you give him the anesthesia, and it will turn into something bigger that will make him go into hospitalization and a lot of more bad stuff. And as we conclude, I want to extend my heartfelt gratitude to two remarkable mentors that have greatly enriched this presentation with their wisdom and expertise. Dr. Nadia Sqali and Dr. Asma Asqali Husseini also, for helping me in this presentation. And there is the form that you can just complete so that I can have your feedback, because it truly makes a difference. I like it when I have your feedbacks. And thank you a lot